My name is Jeremy Peterson. I'm a student physical therapist at Campbell University, and today I'm going to demonstrate glenohumeral joint distraction. Joint distraction is one of many passive joint mobilization techniques physical therapists can use to help restore function and reduce pain for patients with joint stiffness and/or limited range of motion secondary to pain. So as you can see here, I have the shoulder complex, a model of the shoulder complex. Here we have the clavicle connecting to the acromion of the scapula. This is our scapula. This is the anterior face, the subscapular fossa. Here we have the humerus, the anterior side of the humerus facing toward the camera. So for glenohumeral distraction, I want to place the head of the humerus as close to the loose packed position as possible. So in this case, I want to bring it out into 55 degrees of abduction, 30 degrees of horizontal adduction, and distract traction directly away from the glenoid fossa. So I'm essentially creating a small separation between the humeral head and the glenoid fossa. And this can hopefully allow for some increased joint nutrition, and we want to aim to reduce the patient's pain as much as possible. I want to first ensure the patient is in a relaxed position. I have the patient lying supine. I'm going to place the glenohumeral joint as close as possible to the loose packed position. So in this case, for the glenohumeral joint, it is 55 degrees of abduction and 30 degrees of horizontal adduction. I want to place my mobilizing hand as close to the joint line as possible, and my distal hand is supporting the arm around the elbow, around the distal joint. I want to create a mobilizing force through the long axis of the humerus to produce distraction, and it's going perpendicular to the treatment plane, in this case, the glenoid fossa. So the idea here is to kind of separate the humeral head from the glenoid fossa, and with that joint separation, it's going to allow for increased joint nutrition and perhaps a reduction in pain. Alright, so that technique that I just performed, it's called glenohumeral distraction. It's just kind of a fancy word for kind of separating the head of the shoulder from the shoulder blade. So essentially it's just kind of bringing that space out a little bit, kind of enlarging that space, and it's going to kind of help bring some nutrition, get some fluid going in that joint, and it can also help kind of relieve some of the pain you've been having with your shoulder. Okay. So essentially we can keep doing that technique along with other manual techniques to kind of help improve your function and improve any pain you've been having.
All right.
A cadaver study published in the Journal of Manual Therapy in 2009 with 12 experienced orthopedic physical therapists performing glenohumeral distractions found that humeral head displacement was largest in the resting position, followed by neutral, and then the end range position. More joint mobility was gained with distraction in the end range position. This distinction lends important information for the position the therapist may choose to use when utilizing glenohumeral distraction, depending on the goals the therapist is hoping to reach through his or her intervention. A study in physical therapy, the APTA's journal, in 2006 found that high-grade mobilization techniques at the glenohumeral joint were more effective than low-grade mobilization techniques for improving passive abduction, passive and active external rotation, shoulder rating questionnaire scores, and shoulder disability questionnaire scores for a cohort of 100 subjects with adhesive capsulitis. Thus, for therapists wanting to improve joint mobility, high-grade mobilizations would be preferred over low-grade mobilizations for those with frozen shoulder. This study is not specific to the glenohumeral distraction technique, but does speak for the usefulness of passive shoulder mobilizations. An older study in 1985 in the Journal of Orthopedic and Sports Physical Therapy found that in 20 patients with painfully restricted shoulders, joint mobilizations combined with active exercise was better than active exercise alone for increasing passive shoulder abduction. And there was better improvement in pain scores, although this finding was statistically insignificant. However, this does speak to the power of combining active exercise and passive joint mobilizations for the glenohumeral joint.